Hello, and welcome to the final discussion in the Policy and the Pandemic series, Racial Disparities and COVID-19. I'm Whitney Sheridan, Director of Communications for the School of Public Policy in the College of the Liberal Arts at Penn State. The current pandemic is exposing and exacerbating existing social inequalities. On average, the CDC has found the death rate of COVID-19 for Black people to be more than twice as high than for white people. And for Latinos, it's 50% higher. That's despite the fact that Black and Latino people make up just 30% of the US population. We'll talk about the reasons for this disproportionate impact and the policies that have driven where we are today, as well as what can be done moving forward. Before I introduce our speaker, I want to encourage your participation today and invite you to type your questions in the Q&A box at any time throughout the discussion. And now I'm delighted to introduce Nikki VonLockette, Associate Professor of Public Policy and African American Studies at Penn State. Professor VonLockette's research focuses on economic and social inequalities, such as the impact of residential segregation on unemployment and wages for Blacks and Latinos in metropolitan areas, and the effects of workplace occupational segregation. Her recent projects include mapping racial economic inequality and its role in structuring access to healthcare, among other projects. Nikki, thanks so much for being here.
Thank you, Whitney, for including me and facilitating this really important conversation, both today and the series at large.
So I guess we should start out, the biggest question here is, why are there higher numbers of infection and mortality rates for people of color? And I'd like you to go ahead and explain some of the broader context behind this.
Right. So, Whitney, if you don't mind, if you could put up I'd like to start actually with, and students in my class know I do this, and I pretty graphs. So I sent this to Whitney, and I said 5 times. So Whitney first started off with telling us about the death rate, the disparity in the death rate, and it's substantial. But the hospitalization rate, so we can measure COVID prevalence, right, by hospitalization, by death, by exposure, et cetera. So, and the rates look somewhat different depending on which of those outcomes. So Whitney talked about death rates, and then hospitalization would be that outcome that would be right before that, right? And so here we see, this is a CDC chart, looking at, this is fairly recent data too, looking at hospitalization rates, and we see that these rates the rates are quite high for both Blacks and Native Americans. We see it a lot in the media about Blacks, but less about Native Americans. So this was actually instructive for me, seeing this chart. And this was astonishing, and they're related, right? So if we look, so you talked about death rates, hospitalization, exposure, all those different outcomes in prevalence are going to be linked to the same causes, the underlying causes, just with worse outcomes. So one of the things, and I just want to clarify really quickly this age adjusted, this notion of why they've age adjusted. So this just adjusts for the fact that some groups, and is really linked to some of the causes, that some groups just live longer than other groups, right? And we know that COVID is highly associated, especially serious, more serious implications of COVID are more associated with older adults. So if certain groups are more likely to be older as a group than other groups, then we want to remove that disparity, which is interesting, right? Because we do know that whites have longer life expectancies than other groups. So it's interesting that in a way that we're not looking at necessarily only raw data, but we've even sort of adjusted for that, and we still see these disparities. So getting into some of the causes. So one is housing. We see a lot about this. So, it's sort of putting together, I would tell my students this when the crisis hit and we all had to sort of scatter. I tell my students, this is a really exciting I'm sorry, that was awful. That you're in it when you're like, this is exciting. This was fascinating. That's a better word, right? This was fascinating to see ways in which science and policy intersected in amazing and astonishing ways. That is, that we have this infectious disease, right? This is all about biology and the physiology of all of this. But in fact, it was very much about social interaction, social structure that really accounted for how this disease spread, right? As we hear in the news today and recommendations today, policy recommendations today about how to maintain the disease, it's all about overwhelmingly about social interaction, right? So housing, where people live. So then, and I as a sociologist, really come at this from thinking about those social structures that govern interactions and social interactions among populations, right? So housing is a big piece of this, housing and residential status. That is, the disease spreads very much about proximity to people. Space is really important with this disease from a physiological point of view. Socially, in terms of how our interaction, our country, the US, is still very segregated by race, right? And on a lot of different levels. And so crowding, housing, the number of people per houses, the number of units per, say, structure, those are going to vary significantly by race and ethnicity. I was reading a bit about Native Americans, and I think of reservations as being really, really large, but in fact, housing even on reservations is still very poor, the highest rates of poverty on the reservations than anywhere in the country, and the housing reflects that, right? So that there are many people in one dwelling that is rather small, and that it sets up a really an enormous risk for exposure and spread. They talked about scientists were finding clusters of the disease clustering in family groups, work groups, and friendship groups, right? And then also Blacks and Latinos in this country have a higher level of what we call urbanicity. That is, they're more likely to be in urban areas. Now, I like to sort of caution against the fact that we still have Blacks and Latinos in rural areas in this country and in substantial numbers, but overwhelmingly they're more likely to be in urban areas, and many urban areas in the US were hit first, right? We're seeing it move to the south and to the west more, but we saw some of the early areas were in the north and the east where we have some of the highest concentrations, particularly for Blacks, and then employment. So again, I was talking to a faculty member who said she and her family were spring break when we got back, and they said, okay, campus is closed. She said she and her family had just gotten back from a trip to Mexico. They had no idea what was going on, and the customs officer said, go home, run home, and lock your doors and don't come out. But here's the thing, and we saw on the internet, right? We were all like, oh no, we're all sheltering in place in our homes, and this is horrible. But there were other people who would have loved to have that luxury, right? It seemed stressful. We were all sort of, had to be around our families more than we wanted to be. But that was a problem, right? That some people wish they had had. And it became really clear to us after a couple of weeks of sort of getting our bearing that really there were people who were going out to work, right? We were so happy that we could still go to the grocery store, that we didn't have to just rely on what was already in our homes, that we could at least go to the grocery store. We could go, the hospitals were still working. That there were some people who were out there who were kind of holding down our communities. In many metropolitan areas, in particular many cities, those overwhelmingly in a lot of places were people of color, right? I was looking at particularly for Latinos and Latino immigrants, and those are two different people. There's a large group, most of the Latinos in the US are native born, but particularly immigrants were simply not able to stay at home, right? This was not an economic reality. We had, and one of the concerns about is that there were no job protections. There may have, broadly, right? There may have been opportunities for some workers those workers who were able to leave the workplace but still get pay, or those who who weren't able to preserve their jobs but could still afford, right, to leave their jobs if their jobs were like, look, if you leave, there's not going to be a job here for you. Though there were substantial racial disparities then, and all of this predated the crisis, right?
Mm-hmm.
So these are the kinds of pre-existing structural inequalities: housing, employment. One of the things from a policy perspective that was really troubling was that the worker protections. Okay, now, so within the workplace, right, we've got people who have to go to work, cannot afford to not go to work, and nor did we have job protections at a federal level, right? This is one of the things that we tried to do, that the Stimulus Act tried to do, and the second Stimulus Act, and I'll talk a little more about this later. The second Stimulus Act is really trying to beef up those protections for workers. That is, that if people need to leave, that we essentially have a kind of leave for them where their jobs are intact. But really, we didn't have that at the real sort of shock of the crisis, right, where we were sort of steeply climbing up that that graph. We didn't have these protections. And then those who were in the workplace, right, and these are much more likely to be, in many areas, much more likely to be people of color. There was no oversight of worker protections, what workplaces would look like, what it would mean for people to have to go to work. Not even in health. We remember some of this from healthcare workers. We were shocked that we could be
Mm-hmm.
such a wealthy country and not have enough masks for doctors and nurses. We didn't understand.
Mm-hmm.
I'm so glad Kitty is joining the conversation. That we didn't understand. We didn't understand what, we couldn't comprehend the notion that we didn't even have the correct protective gear for healthcare workers.
Right.
But then imagine people working at the grocery store, right? People
Mm-hmm.
imagine, and there weren't, we were slow to get guidelines out to, that is, and by that I mean that's a polite word for saying recommendations. We still to this day, as far as I understand, have no mandatory what OSHA might actually regulate, mandatory regulations for protections for workers. This is
Mm-hmm.
key, right? This is key for what the experience is, what the exposure level is for those workers. I mean, I saw, you see in a city like Philadelphia or Chicago, you've got
Mm-hmm.
bus drivers, city bus drivers. The buses are still working. People have to get around. And those workers without masks, without, we've got cities who aren't providing these, nor do we have anything from the federal government insisting on this. And so what was interesting to me was at the very, very beginning, how companies that even wanted to try and make their workplaces safe. Target was a real leader in this, from my knowledge. Where were slow to get even guidelines of what would decrease exposure in those spaces. And so some companies were just figuring it out, right?
Mm-hmm.
And that really was, again, those things that really sort of shot that curve up really quickly, and all that fumbling at the beginning that really kind of contributed to that huge spike. And if we look at 5 times the rate of hospitalization, we're going to have even greater if we have just if we have levels of just prevalence, that is, people who have it but might not don't need to be hospitalized, or simply those who are exposed. It's going to be radically more than even 5 times.
Mm-hmm. So a lot of the factors that you're talking about really have to do less with what's often referred to, especially in the media, and what I titled for this talk as racial disparities, but it's more about the social and health inequalities that are caused by existing racism that we see, and the systemic racism that we have in this country, and that have gone back for generations. And can you explain a little bit more about that, especially things like that we've seen based on the places where we have historically seen people forced into, segregated communities and, redlining districts, things like that, where these are people who have less access to healthcare, who are exposed to, more pollutants, things like that.
Right. So one of the things that really amazed me that I came across within the past month or so was an article in the Lancet. So this is a finding in the Lancet. The Lancet is one of the top medical journals for doctors, and they found a strong correlation, that is, there a strong association between respiratory illness and respiratory illness that like asthma that that needed emergency room, so severe cases of asthma, and redlining. And they found this association. So redlining, some of you may have heard of this term, and it's being brought out as we're talking about systemic racism, systemic racial inequality. Redlining was a practice the U.S. federal government ended, but this took place, I want to say, it was starting in the 40s, particularly as segregation was really starting to climb in the U.S. And redlining is really thought to be one of the sort of many chief causes for why our cities became neighborhood and became segregated in the U.S. So this was the practice of, before computers, there were literally maps. The U.S. government would produce these maps, the housing administration, and they would take a red marker. I keep on, just for demonstration. They would take a red marker and they would draw a red line around areas. It was actually a color-coded system, so there were other colors, right? Red, green, yellow, and all of them meant the categorization scheme was lend, do not lend. That is, given what we know about these various neighborhoods, these were all neighborhoods throughout the entire country, making recommendations to lending institutions about whether or not to so essentially your neighborhood got a score or a kind of recommendation from the government. Black neighborhoods were overwhelmingly got that red line, right? And so what happened is, and we found even those that were more sort of solid, that were middle class, Black neighborhoods, those still, that we found that racial composition was a stronger determinant than even poverty, which is still a substantial factor. And so redlining, so this is one of the things that really sort of devalued those neighborhoods, devalued those homes, et cetera. To find that practice was ended, it was outlawed, right? We have, I thought it'd be fun. If someone can tell me, you can put it in the chat. There's this an amazing civil rights, landmark civil rights anniversary last week that's actually related to this. So if anyone can tell me what that is, that'd be fun. I don't know, you could win this red marker.
That's a great call out for encouraging questions in the chat.
That can happen. Hey, Google it. So we ended that with the variety of landmark civil rights legislation that was passed during the civil rights movement, right? The U.S. government no longer does that. But the finding is that neighborhoods today, right? This Lancet piece came out, I want to say 2019, that today we see patterns of respiratory illness associated with whether that neighborhood had been redlined. So there's several things I want to note from that. One is that means that the persistence of that structure of segregation not only is still there, right? Those neighborhoods, the racial compositions are still very homogenous. They're very like same people in those neighborhoods. But that the valuation to those homes, the characteristics of those neighborhoods that lend themselves to other types of inequality, i.e. health inequality. And another point I want to pull from this is that with respect to COVID, that the key underlying factor that accounts for the disparity in death rates and hospitalization rates, that is the more serious outcomes, is attached to pre-existing racial disparities in health. Respiratory illnesses being one of them, right? So that Black children have significantly higher rates of asthma, as do Blacks, but we see childhood juvenile asthma, and then pre-existing conditions that existed, substantial racial disparities in heart disease, cancer, diabetes. All of these things have been around for over a century, but we see a persistence in them. And we see it exacerbated when we have these, what we call acute crises, right? So that in fact, there's always this, so I saw it, Catherine Baumgartner. Yes, the Civil Rights Act of 1964 was signed by Lyndon B. Johnson last week. The anniversary for that was last week, and there's this wonderful picture of Martin Luther King standing behind him. And so, and one of the reasons I thought it'd be fun to sort of share that is what's important about that is that we thought we did it. We thought we did it. We thought we in 1954. Brown versus Board of Education, where we have a decree to desegregate our schools. Our schools now, our levels of segregation among our schools exist today at the levels before Brown versus Board of Education that mandated really Brown versus Board of Education. Our levels of residential segregation have not changed significantly. They've gone down for Blacks, but not substantially. And so that we see not only the same patterns of structural inequality, but we see their consequences. You heard a similar story with Hurricane Katrina. People age.
I was going to ask you about similar patterns that we've seen.
A great question. So and it was you heard the same thing. Trivia. Well, this trivia thing is fun. Another anniversary coming up related to this conversation. Anyone want to throw it up in the the chat room? That Katrina. That again. And it was to hear scientists talk about, the geological scientists, the engineers talk about, they could tell you before, and they had been telling government officials, local officials, etc. Here is exactly the neighborhoods that are going to be most exposed to most in danger and they knew, we know the cycle of those events, of those disasters, particularly in those areas in the Gulf, but they could tell you specifically what areas and what groups were going to die, and they did. And it's those, and that came from not some prescient knowledge, right? They weren't mind, it was just, these are the social structures, the social and economic structures that that are in place, that we're not talking about until there's a crisis like this. And so rather than really focusing on COVID, it's about really focusing on these structural inequalities.
Yeah. And I want to ask you about some of the policies that we can put into place so that we're not put into positions like the ones that we're in now. But I want to address this question that we have here from Rob Brown, who says, multiple studies have shown that nursing homes with higher amounts of Black and Brown residents have had higher COVID cases and deaths, no matter the quality, size, or location of nursing homes. Can you explain this information?
That is astonishing, actually. I thank you for sharing that with me. I've not seen that study, and but it doesn't surprise me. Here's what I think is happening. One of the things in terms of, again, pre-existing disparities that when we're talking about racial disparities in health, one of the things those studies always show, and this is sort of the heart of the work that I'm doing now. One of the things that these studies show is consistently show is for any health disparity, when we control for the things that we know are associated with health, class, poverty, education, even access to healthcare, we still see what's called a persistent race effect. That is, there's something just about being, and particularly for Blacks, there's something just about being Black in this country. So let me give you two examples. There was an astonishing study that came out several years ago, just like 2 or so years ago, finding that the levels of infant mortality is it's something that we've kind of dealt with. We've done, right? You know, babies don't die, you know, necessarily as much anymore. And we use infant mortality really when we're doing cross-national comparisons to sort of see how well that nation is. It's a really good indicator of how well that country is doing in general. Economically, really. But we can see those patterns even among groups here in the US. The infant mortality disparity between whites and blacks is higher. The overall absolute rates are lower than they ever were, obviously, but the disparity between blacks and whites is higher than it was in 1850 when we first started taking the indicators. And similarly to the nursing home study, the disparity is reduced, but does not go away even when we control for class and education. Similarly, maternal mortality and morbidity, that is if a woman either dies or if she has an enormous amount of, is sick because, or some type of poor health outcome as a result of the pregnancy or delivery, there are substantial disparities. This got a lot of attention when Serena Williams almost bled to death when she gave birth to her child. And when Beyonce got this, all of a sudden we were talking about this because these were famous celebrities that could not be, they're very, very wealthy and they're doing well, right? But Beyonce had I was very surprised to learn with her last pregnancy had substantial, was in bed rest. I mean, she was so sick with the very most, typical diseases that we find that are associated with racial disparities and maternal outcomes. There's a diabetes that's associated, the preeclampsia, all those things, and that poor woman had all of it, and people were shocked because we thought she has certainly earned enough money to, but we know that that's actually quite. Those are actually quite common for Black women, regardless of their. And let me just tell you really quickly. The theory for that is what is commonly called the weathering hypothesis. That is, there's a health tax for being Black. That we think that what we call racial stress. There are a lot of indicators of inflammation and stress in the body that scientists have found that are much higher for Blacks than for whites. And all of those indicators and markers are more highly associated with bad health outcomes. And those are about being Black. And in some cases, we actually see Blacks who are more likely to work with whites who actually have higher levels of those things. So the idea is there's sort of this thinking that there's just a sort of racial stress, and now that we're in the middle of talking about, and I'll preview our next series on this idea of policing and thinking about the kind of stress that causes for people who don't die but look like the person who just died, right? That causes a kind of racial stress, or ways in which the Karens. Just yesterday, the woman who verbally got assaulted a man in Central Park, the bird watcher. I won't go into if you've heard of it. She was charged yesterday, which was surprising to people, for falsifying a criminal act. And so think about the racial stress. The guy was out bird watching and all of a sudden finds himself accosted. These are not anomalous, just the big ones make the news. This happens every day. And that causes a kind of racial stress. And scientists, health scientists believe that they call that racial stress, and those things are associated with other kinds of health outcomes.
We have a question here. Catherine is, or maybe not, maybe it's more of a comment. Catherine Baumgartner is saying, I would guess that there would be some relationships between availability of Medicaid beds in nursing homes and proportion of Black and Brown patients needing those Medicaid beds. So if more Black and Brown Medicaid patients need those beds, the rate of disparity would be higher. In my own community, the number of patients dying in nursing homes is disproportionately higher in the Medicaid nursing homes than private pay ones.
That's interesting. Is that I think, again, that's an
It's
interesting,
yeah.
that's a really interesting point, Catherine.
Mhm.
And I think that I'm guessing you're speaking to the sort of the article, the study that someone else mentioned around the
Yeah, and
disparities.
he's following up right now too. And he's
Okay, great.
saying
It's a great conversation.
yeah, we have a
Um,
nice dialogue here going, and he's saying, is the higher numbers also relates to the staff of these nursing homes, since many lower level staff members who care for these residents are people of color in lower socioeconomic groups.
so I'm not sure about that, because I'm not, what would be the mechanism by which we would see differential care? But
Mm-hmm.
I am interested in the Medicaid piece. Is interesting. If the
Mm-hmm.
proportion of Medicaid beds is different, then we have people who've lived a lifetime of poverty,
Mm-hmm.
and then we have this sort of have access to, say, a better facility, better care, but at the end of life, right? So and we
Right.
know a lot of this is cumulative, right? A lot of health
Mm-hmm.
disparity scholars talk about this kind of cumulative disadvantage sort of adding up and creating these disparities later in life.
Well, I want to go back a little bit to some of the things you were saying, especially with regard to was it Venus or Serena Williams and Beyonce and others. And I've heard this, no matter what economic bracket you're in or income bracket you're in, you know, a person of color receives not the greatest often health care, just based on your race. And that's been the way it's been for generations. So we're talking about racial disparities in our healthcare system that have existed for many generations. And how do we go about trying to remedy these disparities, especially in a situation where we're dealing with a pandemic and we have so many people who are in need right now? These are things that are part of the system that we can't obviously fix overnight, but a lot of this needs to be fixed in the short term, but
Mm-hmm.
also we need solutions for the long term as well.
Mm-hmm, mm-hmm. That's a great question, and I think that's important. And you know, and again, I'm sorry to kind of keep bringing up this other crisis, but it's kind of hard to ignore it. But it's fascinating, in the middle of the COVID crisis, the policing crisis, but the policing crisis as it points to systemic
It does.
discrimination
They're not they can't be separated.
they're not unrelated. And one of the things that always amazed me, so I studied with graduate school, really one of the sort of top race and health scholars, health disparity scholars, and I was really interested in employment and labor market outcomes. I mean, he was really interested in health disparities, and we were talking about the same thing, right? That when we that what was underlying those two what seemed like really disparate outcomes, labor market disparities, income disparities, and health disparities, were really structurally the same thing, and it, as well as the criminal justice system. So I was doing I don't study the criminal justice system, and I was looking at some work on how segregation was affecting wage inequality, and I was finding really bizarre results that just weren't making sense. And I presented this at a conference, and a white woman who was at the Association for Black Sociologists said, "You need to consider incarceration." Incarceration is this intervening factor that accounts for some of the wage disparity in between Blacks and whites, particularly Black and white men, because of Black men's overrepresentation in the carceral system. And there was just in the New York Times if we look at wage inequality and we do not account for the incarceration difference, we will not get at. And this was exactly what I was finding in my findings. And when I accounted for it, everything, you know, had this sort of narrative that I think fit the relationships that we would predict. And I started to see this relationship between all of these things, right? The education system, the carceral state of incarceration, employment outcomes, health outcomes, all of these things. Every time I talk to scholars who are looking at racial disparities in any of these things, we were always talking about the same story, all of the same underlying things. And so I've been working to put all of these things together in one model. If we could understand better any one of these um, outcomes that we can understand, particularly that persistent race effect that exists after we account for everything else that explains it for everybody. If we, I'm in the middle of literally analyses, if we actually put that structural inequality, a measure of structural inequality, this broader interdependent, this complex web of structures together, will they explain that last race effect? And I'm finding I found that was the case with wage inequality, and now I'm bringing it around to health inequality, et cetera. I think with, if there's another question, Whitney, you're just gonna have to do like my husband and my family, just you, honey, you have to,
just cut in here.
have to, like, you know, you
do. Yeah, Lillard has a question. He says, we often look to DC, but what state policies exacerbate or ameliorate these structural problems that you've been describing?
Ooh, that's fun.
Oh, that's fun.
That is good fun.
I love it.
I'm really interested. Two things that occurred to me. So I've been going through the CARES Act, because what else would you do in the summer but climb through federal legislation? I've been going through the CARES Act, and then what's on the table now is the HEROES Act. And also who names these things. That's really great. And so the CARES Act, and so what's really interesting to me is that a lot of the money, so these are the stimulus packages. And I think if we talk about what we could do, I think looking at what's gone on with the stimulus packages and the recovery packages is really important. And I think some really amazing measures have been taken. But one of the things that concerns me is that a lot of the money goes to states. That's good. States need money.
Okay.
But historically and continually, we've often used this federalist, right, you know, sort of from the government to states as a way to allow some states to disperse money in the ways that they see fit. And that there's some good reasons for that, right? But it can have the effect of, and often the intentional effect of allowing local practices to prevail in ways that borrow from what in some cases can be racist policies. So, for example, unemployment insurance is a big piece of both the first stimulus and the second. The idea we really need to extend this unemployment insurance, and this is where it's if I've got the timing right, I think in the HEROES Act, right, which has not been passed, this is one of the big hullabaloos, is that, you know, many don't want to extend those employment benefits. And what will happen is unemployment benefits, those are one of the things that, again, goes to the states. All kinds of benefit programs before went to the states. Let me give you an example of historically what we know has happened. So, for example, and is really was an important measure with respect to the racial disparities that we see today. The veterans, why can't I remember this? World War II. What started with the M? Why can't I'm blanking on this? When the money that gave veterans money to go to college, to get low interest loans for housing, which kind of created the middle class. I don't know. Someone.
The GI Bill.
Thank you. I don't know where I got the M from. I threw you off with the M. That was
for
just
that person who chimed in.
Thank you.
We appreciate
GI Bill. So the GI Bill was distributed by states, and the main and one of the thank you. That's my husband. One of the he's an engineer. One of the reasons, who's heard me make this argument many times, you know, one of the reasons that the GI Bill, one of the arguments that one of the historical scholar about the GI Bill was that it was particularly distributed. The idea was to distribute. You would think that would be federal, right? But it was decided to be distributed by states, specifically so that Southern states would have, who really did not want Black veterans to have those benefits.
Right.
This allowed them to say, you're not going to get, and they did. Black veterans did not get those, overwhelmingly did not get those, benefits. And interestingly, one of the reasons I think I have a PhD is because my grandfather, who is a veteran of the Second World War, happened to be in a state where that did not happen, and got a college degree and an advanced degree, actually, and did well, just like many other GIs did, because of that, which was the whole idea, right, of that. We see disparities in how various benefits are distributed by the states, and some of those, and a lot of, like I said, for a lot of good reasons, many that have nothing to do with race, but we sometimes see race as like this. So for example, the standards for how food stamps get distributed, or other types of those benefits. Some states will just put up higher requirements, more strict work requirements, et cetera, et cetera. And that concerns me, especially around unemployment insurance, and some of the things. So there's trillions of dollars in these stimulus, and the oversight issue is really concerns me. Not only in some of the potential intentional discrimination, but in some even in mishandling, even in people who are making decisions who may not always have the best information or the right expertise. I think HUD could and should be doing a lot more here. The first stimulus had small, it was all relatively small, but this was we're talking trillions, where small becomes, so I don't know, maybe just a small billion or two for these community development block grants to communities. And the idea in the act was for communities that were most hard hit. So like I said, these COVID disparities are about place, right? Overwhelmingly. And so so the idea is for these to go to specific places that are really struggling with this. And so that we can have extra protections, that we could deal with some of these issues around overexposure. And that might not get, if we're going to leave, I think, a little too more discretion than in some of that, then I think that could cause problems, and I'm concerned about that.
So I wanted to ask you a couple things similar to this. So 20 cities and counties and at least 3 states have recently declared racism as a public health crisis. Do declarations like these, are they helpful, at least in bringing awareness? They don't usually prescribe specific actions or allocate funds, but we've been talking about what more can be done at the state and local level, but is this something that if we start to see more states and local governments start doing, perhaps this can have a ripple effect?
So that's interesting. So those declarations, my guess is, and again, in our discussion, if anybody has some other theories, I'd be or knowledge, I'd be interested. My guess is those declarations are about potentially federal funds, or federal funds, or even perhaps foundations. The other thing that has been mind-blowing is the way in which private capital is being leveraged to both in the US and globally to deal with this crisis. There's a very interesting way in which capitalism might be having a sort of, it might be in some, kind of some heroes and saviors here funding startups for the vaccine. Providing when I talked about this in my class, when governments were not providing, couldn't provide generators and extra generators and masks, that there were private, sources that were. And I'm also hearing about sort of, and so that people might be, and I'm also hearing about conglomerates of these, right? When the Gates Foundation, Melinda Gates, and Oprah and some other less wealthy people all got together for what I was like, whoo, that's some money. That's a lot of money. There's the stimulus, and then there's that, right? And so that they were specifically, I know, they were specifically early on concerned about and dedicating their some of their efforts towards specific places that were being hard hit by in terms of racial disparities by COVID, and that so then those declarations make it easier in some proposal you can imagine saying, it's formal, it's official, we have a problem. And so I can and I think I don't think that's inappropriate. I think it would be, and you have to have, and I think in some places I'm not familiar, but there might be actual standards by which you have to provide evidence of, right? And that's then that becomes a handy mechanism for assistance in a variety of ways, not even just payments, but if they were to start to use, it might also provide some legal justification or infrastructure or groundwork for other types of, so for example, school segregation, right, becomes really important here. Or all of the attempts, there have been so many attempts to undo residential segregation that have been fought assiduously by people who think, no, we'll just stick with this is good. And so this might be an opportunity to mount some of those legal challenges again, to really undo these structures. I was thinking about this notion of segregation as a building we built, right? A structure we built that we didn't take down. And I used to live in the Philadelphia area, and there are these amazing old buildings that are really so sound, structurally sound, not all of them, they're so structurally sound, and they're just repainting them and putting up new modernist interiors and renting them out as delightful boutique hotels and lofts and whatnot. And so for me, the metaphor of that, for thinking about what we've done in terms of segregation, in particular, residential segregation, school segregation, and we've just sort of, we've not, until we dismantle, we won't, it will not go away by itself. Just in like a building, a solid bricks and mortar building is not going to go down until you see, like we see all over State College, those huge bulldozers. Gotta have metaphors in teaching.
That's right. So one thing that I wanted to talk to you about is there has been a lot of inconsistency, delays, and some lawsuits involved in the reporting and data collection around race and ethnic data, all kinds of data, in fact, around COVID-19 cases. And several states don't even report racial and ethnic data on COVID-19 cases. Why, and what can we do to change this? What additional impact does this lack of reporting have on our communities as far as health outcomes?
You know, another great question, Whitney. Disheartening. So there was this I imagine is similar to a similar phenomenon when early in the Trump administration to actually remove the reporting, so well before COVID, right? To remove reporting of race in government statistics. That and I think behind that, so and there were literally from OMB, this is the sort of oversight of federal agencies, an attempt to actually forbid federal agencies from collecting data by race and ethnicity. So I think asking me to make that make sense is impossible, but I can kind of get at, and at the sort of the incentive and the motivations. You know, my sense is that, again, similar to in almost a sort of counter to the declarations we were just talking about. Again, not having, if we don't know that there are disparities, then we can't leverage federal resources, then we don't need to.
I guess that's the biggest point. We can't provide the testing, right? In the right place, in the places where they're needed. We can't provide the PPE. We can't provide public service messaging targeted to communities who might need different messaging, because some of these communities don't have the option of social distancing in the same ways, perhaps. And public transit, you know, you might need different messaging in those,
Mhm.
in how to
Or
distance
mitigations, right? Or
or
mitigations
mitigations.
where workers
Exactly.
are really, right, they're dependent on public and mass transportation even to get to
Right.
work, right? Yeah.
Right.
Hmm.
Right.
I
So
think,
I guess the
yeah.
bigger impact is, because we don't have this consistent data, and it doesn't look like we're getting any consistency anytime
Hmm. Hmm.
soon.
Hmm.
The CDC has just released this because of a lawsuit from the New York Times.
Hmm.
Um, what can be done? I guess I don't
Whew.
know.
I mean, I
That's
remember,
the
does
biggest
anybody,
question.
I got you. No, I'll figure it out. I'll figure it out. And I'll let you know.
You figure that out,
I'm
and then
gonna
you'll
write
be
a
the big
letter,
hero.
and I'm gonna have my 4-point plan too. But I mean, Whitney, really, that was really, and this was, there's, we were supposed to feed Whitney some questions. I didn't feed her these. These are awesome. But I mean, it's the politics of it. One thing I'm
Mhm.
also hearing that I didn't know, it's also a census year. I mean, 2020, what a year, huh? And so
And that's the other thing.
it's also a census year. And so it's really important. And there were also moves by the Trump administration early on. Academics and, and particularly demographers were horrified. They wanted to remove some of the race questions, the ethnicity
Mhm.
questions. It was like, huh, what? And so a similar thing. So what I'm hearing a lot from activists, is fill out your census form. That census, understand that if we have data can really be used to help us. It can be used in in some of these policy ways that can help with this, right? And so if that gives us that tells us about areas that are particularly that have particular needs. And again, if I were to think about incentives, I can't imagine the current administration being really, one argument might be if we have very few ventilators, if we still have a sort of shortage of supply of ventilators, maybe it should go to these areas that happen to have more of those. If we were to send some more of those to these areas and not to other areas, and those areas happen to have more people of color, yeah, okay. Like I just really don't think, anyone in this current administration is really, excited about that concept.
I
So
know.
suppressing data, suppressing information could be a sort of, an easy task to make that problem go away, I guess.
Mhm.
Astonishing but true.
Right. And Lillard's asking, as ethical leaders, what can our students do as they enter the public service to help reverse these racist policies and outcomes?
So one thing, thank you, Lillard. So one of the things I want to try and do is help people understand at a sort of smaller level. It's really um, useful. We can talk about, the federal, we always want the federal government, and that's important. That plays a role. But I want us to leave these conversations, which can leave us very heavy, which can leave us very frustrated. Someone talked about the notion of despair.
Mhm.
What can we do at a local level? But we can also talk about also for our students as we think about. I teach courses on management, thinking about our courses, our students, preparing our students to be leaders of organizations. So again, I think that I think those are sort of two things. If I think about the individual level, I remember this. Remember when early on people were hoarding food, and they were talking
Mhm.
about, people brought up the case of the WIC labels, that women, infant, and children sign with
Mhm.
food, that they were limited to only certain foods, so please don't overbuy those foods. They can't buy other stuff with the WIC benefits, so
Mm.
please leave those foods on the. One of the things I thought about at the individual level in our communities, in our cities, is similarly, a lot of us are being asked to fill out surveys, like, around reopening, surveys around your preferences. And we tend to fill those out from our own perspective, what our life is like, what our needs are. Those are going to vary. I want to encourage you to think about, and I'll keep it kind of general, but I want you to encourage you to think about other people who don't have. I can't imagine. We've been in terms of essential workers, we've been so, we've had all these honorifics. These people are so great, they're so wonderful. But I always think about schools closed. Who's watching these kids? Who's watching their kids? And the
Mhm.
presumption that they live in a home where there are two parents or their grandparents. Think about those things as you interact. If you're a manager, if you are if you are a supervisor, or even as a co-worker, to think about not just the preferences for you and your family, but thinking about those who are you're connected to in one way or another. I saw a funny from an essential worker posted. They say I'm an essential worker, but my paycheck says I'm not essential, right? So, these are ways in which hazard pay as part of the, there was some of this in the first act, but more, they're pushing for more hazard pay. Workers are pushing for hazard pay. Ask your, if you go into a hardware store or grocery store and you see workers without mask, and they're, ask a manager, do the workers are they provided masks? Workers are asking for companies to actually provide masks. So they don't have to wear masks, or that mask that can be thrown away at the end of the day. That's a cost that's hard for a low wage worker to assume. I think at the leadership level, if we're thinking about, I was thinking about public organizations, it's again having that, when I teach about issues around diversity, that I feel a real mission in making sure that, I used to teach HR just to people, private sector, public sector, and I felt a mission around helping them understand, if you understand issues around diversity, right? If you even know about a WIC program and how that would affect consumer and consumption and consumer decisions. But even if you are managing a city, a small city, a hospital, thinking about some of these issues, some of the research in health disparities has shown that doctors, other healthcare providers, administrators have a lot of misconceptions, and that education for them is really important in their decision making. And so that really is important. If you are a decision maker and a manager, you have a responsibility. And educate yourself, and ask those around you to help provide education. I think that I've been amazed with the sort of response to the protest and whatnot. I've been amazed by corporate and organizational, both nonprofits and for-profit organizations, who are saying, we're rethinking what we're doing and how we're doing it with respect to structural inequality, right? That is, I always teach my students that to move away from thinking about, this notion of racism as a sort of aberrant or anomalous, they're sort of bad racist people, and there's some of that. But that where the real action is that's more impactful is around structural inequality. And that really, there's a lot in the management literature, there's a lot in general social science literature, that it's that structural inequality is embedded in our institutions. And in fact, it's this common business as usual practices wherein those types of practices actually, and that inequality actually gets engaged. And so that those are the kinds of, so it makes sense then for organizations, public sector organizations and the private sector, to think about, how is it that we do business without, what are the ways in which we do our ordinary business practices that lend themselves. So like just a quick example, if I were to think about a manager of a public sector organization, it's not even, we would think about hiring like being more, more open in hiring. But we actually know that more of the sort of hiring discrimination comes from not people who show up to actually apply, but that because of structures like segregation, that most people of color don't even know about those jobs to apply for. So that there's a deeper kinds, and that's why these structures are so interconnected. So thinking then about, like we can think about the university or other schools, where you do recruitment, right? Where do you, that outreach becomes more important. So that's one example.
We have a great question that is very similar to the one I wanted to wrap up on, and we're just about out of time. So I'd like to ask you really briefly, what 5 key talking points could we use when educating others around these issues?
You said 5, huh?
They're asking for 5. I feel like we could do a part 2 for this conversation. We barely scratched the surface, but they're asking for 5 talking points.
Yeah, I'm not sure if it's 5 or I'll pick a few. I'll if I get to 5.
Maybe a couple,
And
yeah.
then next week 2 or 3.
And I feel like, again, we could do a whole nother discussion on this.
Yeah, I think we've had some really great ideas. People were helping me out when I couldn't think of stuff. I want to think. I really want to sort of come back to. I think these would overlap both of these. Is this? I think about dealing with housing, residential segregation, healthcare inequalities that are related, but not necessarily even just COVID. So healthcare access, insurance coverage. We're going to have a discussion on ACA coming up. Those things. So housing, healthcare. My big thing, I'm going to stop here because employment's a big thing. So for me in my work is thinking about workers, the employment situation. This is going to be, as the COVID crisis continues, but even after COVID or separate from COVID, that the employment, our workplaces, our workspaces, and think about that more broadly than even our grocery stores, but in terms of our school, like workers in our schools, workers at the university, we receive a lot of public services, but sometimes we can forget that there are people who are workers, who have families, who are part of that, who are providing those services. Our trash, I was really surprised when they weren't taking recycling for a while, and I thought, wow, I never thought of that, right? Thinking of sort of as a way to reduce exposure for workers. So those are the 3 things I would sort of think about in terms of dealing with some of these things. Oh, and I'll leave with hazard pay too. That I think that this is a time when people who are out there, while we're at home mad because Netflix hasn't come up with enough shows. There are people who are out there feeling very unsafe. And what can we as a community and as a nation do about that?
Great. And again, I feel like we could have another one of these conversations easily, but we should definitely be wrapping up. I want to thank everyone for their great questions, and Nikki, I especially want to thank you for talking with us about racial and ethnic health disparities relating to the coronavirus pandemic. Be sure to check out all of the replays from past events in this series on our website at publicpolicy.psu.edu. I'm Whitney Sheridan for all of us here with the School of Public Policy. Thanks so much for watching and have a great day.
Thank you, Whitney.
Thanks, Nikki.